Welcome back to Dr. Martin, Head and Neck Radiology. Today we will discuss an essential and frequent finding in orbital trauma imaging, the orbital blowout fracture. Correct identification of this injury is critical because it directly impacts clinical management and prognosis. Let's explore its definition, imaging features, differential diagnoses, clinical implications, and etiologies. An orbital blowout fracture refers to an isolated fracture of the orbital floor or medial wall, secondary to blunt trauma from an object larger than the orbital rim. This results in a sudden increase in intraorbital pressure, causing a fracture of the thin orbital walls while typically preserving the orbital rim. The imaging modality of choice is a non-contrast CT scan of the facial bones with thin axial slices and high-resolution multiplanar reconstructions, especially coronal views, which are essential for orbital assessment. The most common presentation is an orbital floor fracture. Key imaging signs include discontinuity of the orbital floor, typically in the posteromedial portion, with an osseous defect extending into the maxillary sinus. Inferior displacement of the inferior rectus muscle, which may be partially or completely prolapsed into the maxillary sinus. The teardrop sign on coronal images, representing herniated orbital fat and muscle hanging through the fractured orbital floor, is a classic indicator. A change in the orientation or contour of the inferior rectus, such as angulation, flattening, or bowing, especially when compared with the contralateral side. Entrapment indicators, particularly in children, include abrupt cutoff of the muscle belly at the fracture site, known as a trapdoor appearance. In these cases, the muscle appears kinked or tented at the fracture margin. Limited upward gaze on clinical examination correlates with radiological findings of muscle tethering. Secondary signs include maxillary sinus opacification due to hemorrhage or edema and preseptal or postseptal orbital swelling. Complementary use of MRI may be helpful when CT findings are subtle or when evaluating possible ischemia of entrapped muscle. On MRI, look for edema or increased T2 signal within the muscle, loss of normal muscle architecture, and reduced enhancement post-contrast, all of which suggest compromised vascular supply. The second most common type is fracture of the medial orbital wall, specifically through the lamina papyracea, allowing herniation of orbital fat and the medial rectus muscle into the ethmoid air cells. Additional associated findings include herniation of orbital contents through the osseous defect, involvement of the infraorbital canal and infraorbital nerve, orbital soft tissue injuries, possible combination with other facial fractures. The primary mechanism is a sudden increase in intraorbital pressure caused by blunt force trauma. Common causes include motor vehicle accidents, physical assault, and sports injuries involving impact with objects larger than the orbital opening. Typical symptoms associated with blowout fractures are diplopia, particularly in upward gaze, due to muscle entrapment. Enophthalmos caused by the loss of orbital volume and herniation of orbital contents into the paranasal sinuses. Hypoesthesia of the cheek and upper gums resulting from injury to the infraorbital branch V2 of the trigeminal nerve when the fracture involves the infraorbital groove or foramen. If you want to expand your knowledge on head and neck vascular lesions, I invite you to watch my video about the radiologic findings of Glomus Tympanicum. You can find the direct link in the comments section below. Thank you for joining me today on Dr. Martin, Head and Neck Radiology. If you found this video helpful, please support the channel by subscribing, liking the video, and leaving a comment or question below. Your participation helps us grow this educational community. See you in the next video.